This is chapter 18. It's the periodontium. So first we're going to kind of go over the treatment area. We have a clinical crown and an anatomical crown. Anatomically, the crown is any tooth that's covered by enamel. So in this left picture, it's going to be below the CEJ. You're not going to be able to see it. From the CEJ to the top of the tooth is anatomically the crown. And so the clinical crown is the tooth that's above the periodontal tissues. So in this case, there's not much, it doesn't include down into the sulcus. It just includes from the top of the gingiva up to the top of the tooth. It's the part of the tooth that you actually see. You can see all of it. So on a tooth that has recession, like this picture on the right, the anatomical crown is going to be the same, even though there's recession. You can see that this gum line is lower than this one over here. This is lower. And on this side, it's lower than this over here. So the anatomical crown is still going to be at the same place. It's just that the gingiva has receded. So it's going to be the tooth covered by enamel, which is anatomically correct. The clinical crown is going to be from the top of the gingiva to the top of the tooth. And so this side is going to include some root surface on it also due to the recession. And the clinical roots are done and anatomical roots are done in the same way. So a clinical root is the tooth below the base of the sulcus or the periodontal pocket. So wherever that sulcus is, if it's kind of down here, the clinical root is going to be that part that's covered by cementum, and it's going to be like this. But the anatomical root is going to be from the CEJ all the way to the bottom. So the periodontium. The periodontium, dontia, dontium, dont, donto, any of those mean teeth. And anything peri is around the tooth. The perio is anything that's below the CEJ, the surrounding the root of the tooth. So the periodontium is the area that supports the tooth down there, and it's going to contain three parts. It's the periodontal ligament, cementum, and bone. Those are the three parts that comprise the periodontium. This also goes by the name of attachment apparatus. And you may have questions on tests or boards that will say, instead of saying the periodontium contains which three parts, may say the attachment apparatus contains which three parts. So you need to know that those are two names for the same thing, periodontium and attachment apparatus. The periodontal ligament are fibrous connective tissues that surround and attach the roots of the teeth to the alveolar bone. And the cementum is that thin bone-like covering of the root, and it's completely insensitive. It doesn't have any nerves in it. So it's really easy to remove. It's thin. We want to try not to remove it. It protects the, not to remove it when we're scaling because it protects the root and the dentin. So bone is the bone socket that houses the tooth, or the tooth socket, they can call it. And it's the lamina dura is the tooth socket and supporting the bone. So here's a picture that's easy to see on an x-ray, the lamina dura. It's this white thing right here. And this white thing right here. That, if you go around the whole tooth, is the bone socket. Okay, on every slide. So you should be able to visualize the bone sockets or tooth socket, and it's called a lamina dura. This lamina dura, it's the bony lining of the socket, another way to put it. It's down on the roots, and this shows the periodontal ligament, and the cementum covering this yellow is the cementum that's covering the lamina dura. Here, the lamina dura is going to be right here. That's the bony socket, right there. And then you have this cementum, and you also have the periodontal ligament in between the tooth and the cementum. This is just called alveolar bone or trabecular bone, and all of this is the bone that holds everything together. So let's move back to the gingival tissues. The gingival tissues, you need to be able to pick the different parts out. And so we're just going to start from the top. This is attached gingiva. This part of the gingiva up here is attached. You can't pick it up. It's not loose like the inside of your cheeks. It is just tissue that is adhered really tightly over the bone. So then you come down and you have this free gingiva area. This free gingiva area that's around each tooth like this. And there's kind of a little demarcation or a mark right here that you can easily pick out where that is. And that's the sulcus that you'll be putting your probe down in. That's the part that's loose. It should adhere snugly up to the tooth, but it's not attached to the tooth. So they call it free gingiva. And it's the gingival sulcus on the inside. Then this black right here is the gingival margin. We talk a lot about the gingival margin. This can be red if they have gingivitis, and we can say if it's just on one tooth, they would have localized, meaning it's just in one little area, localized on tooth number 9, and if that's red on several teeth, we would say that these teeth have marginally red. Means it just is going across the margin on each tooth, which often it could be trauma of some kind, but often it will be gingivitis. This is the interdental papilla. It's the papilla that comes down in between each tooth. Should be flat, pointed in between these teeth to maintain health. You can notice that this is not pointed. They have a little gap there. It should fill this whole space. And this is kind of blunted. It's blunting of the papilla. So the periodontal structures, you have the masticatory mucosa that surrounds the necks of the teeth and is attached to teeth and alveolar bone. And you have the gingiva, and that's made up of that free gingiva, the attached gingiva, and the interdental papilla that we just talked about. That makes up your gingiva. So then you have the gingival sulcus, which it could also be called gingival crevice. This location is the crevice between the tooth and free gingiva. It's called the sulcus, or it could be called a crevice. We don't see that very much, but it could possibly be a test question that would use that word. And what that sulcus does, the very bottom of the sulcus seals off anything from the oral environment. It seals it off from anything below, which are the periodontal tissues. Sulcular epithelium is what the skin tissue is called that is in the sulcus. So that's lining it. It's not keratinized. Something that is not keratinized is smooth and loose, and there's less protection. On something that is not keratinized, it allows diffusion of certain materials through the cell junctions and the cell's body. It allows it to go into the sulcus. Sometimes this is a really good thing because if you have an infection down in the sulcus, it will allow your leukocytes and all the things that are going to help come in there and help try to fight off infection. It helps them to kind of soak into the, kind of ooze into the sulcular area. So the depth of a healthy sulcus is 0.8 to 2.1 millimeters. And a probing depth of a healthy sulcus is anywhere from like 1.3 to 2.7. And we call that, we just kind of round that off 1 to 3. A healthy probing depth for a healthy pocket on everybody is anywhere from 1 to 3 millimeters. So deep. Contrast, the keratinized tissue. Keratinized tissue has lots of vesicles containing a protein that turns into keratin when the cell dies. So it provides the epithelium with protection and resistance to traction and friction and is impermeable. So the non-keratinized tissue is permeable. The keratinized tissue is permeable. Keratinized tissue is thicker tissue, and you'll be seeing some examples of those as we move along in the course. So the gingival crevicular fluid. This is the fluid that's down in the pocket. So here's the sulcus in here. And the crevicular fluid or sulcular fluid is a serum-like fluid that seeps from the connective tissues. It all goes from here through the epithelial lining into the sulcus or pocket, if need be. So we call this the gingival sulcus. Here's the oral epithelium. It's the tissue on the outer side of your papilla. And here's the sulcular epithelium, which is down in the sulcus. So that's easy to remember that it's on one side of this sulcus or pocket has to be the sulcular epithelium. The other side is the tooth. So then you have all this connective tissue. You have your junctional epithelium down here. What the junctional epithelium is at the very base of a sulcus, and it is going to hold the bottom of the tooth up close to the tissue. And it forms the base of your pocket right here. It'll be from here to here. Okay, so then now you have all these gingival fibers that we'll talk about. We have all these different kinds of periodontal ligament fibers down here on the root because this is the mucogingival junction, and it's going to connect the gingival part to down here by the root. And you have your periodontal ligament. So the interdental gingiva is called the papilla, and that's usually what we'll call it. The location, it's interproximal, or they may say proximal. It's also called an embrasure. And they have different types of an embrasure. They have a type 1 embrasure. It would be perfectly healthy. It's the gingiva that fills the interproximal area. It's flat, pointed. It could, if it's healthy, it could be cratered or bulbous if it is inflamed or unhealthy or rolled. The very center of the caul is non-keratinized, and the caul is a depression between the lingual and facial papilla that conforms to the proximal contact. Most of our perio infection begins in the caul. So here's what that looks like. These are the sides of molars and anteriors. So you have a facial side and a lingual side. Here's the lingual, and here would be the facial of that tooth. So what you have is, this looks like a lingual, and this looks like a facial of a molar. So in between the teeth, this area right here is where one tooth contacts the other tooth. It just contacts it in a little, looks like they may contact the whole way down, but they don't. And the papilla in between will be tight above like this on this side, and hopefully up and pointed and nice and healthy on that side. But then in the middle, under, you have this contact. So there's kind of a crater right here. A lot of times it's right in here between where the teeth are touching another tooth, in this little depression area, or depressed area, that we find most periodontal disease starting. And it's kind of obvious because it's going, if you put a piece of floss even in between and kind of unch it in between the contact, it's straight, and so your floss may be going, you know, straight like this and flossing, but it's not getting down here. So the caul area is going to be hugely important, that we kind of turn our instruments inside the tooth and not make it too flat, and we'll be showing you how to do that. These are embrasures. So this is a normal embrasure in between two teeth, and this normal embrasure has, it's flat, it's pointed, fills the space in between the teeth, and it looks pretty healthy. It looks a little redder in this area, but I think that's just the coloring of this. So class one would be like that one tooth that we saw that was, which was kind of, looks like someone just kind of chopped that off. It's blunting in between there, and so that would, if you only have about that much, it would be a class one. A class two embrasure would be if there's a lot more, and you have a lot more space. It can be even down here a little bit, and you have a lot more space, and this you could put a toothpick through, or whatever, but it's a loss of papilla there. Class 3 is a complete loss of the papilla. You can, it's way down here, the tissue, and this is like just like a big hole that you are seeing the roots of the teeth, and the papilla is way down there. So you'll need to know, like by picture, what classification these are, but it's pretty easy to kind of figure out. Okay, so this picture is going to be showing you the junctional epithelium. And what's important for you to know is that the junctional epithelium is on the enamel. So this is a larger picture of this right here. So you can see that they just cut out a bit of the tooth and the root over here, and just kind of cut that little section out. And that little section is there. So you can see where the tooth is going like this. This black line right here is the tooth, and it's going straight down and onto the root. So this is all enamel because it's the tooth. That's enamel. And here is the gingival sulcus right down there. And so on this side, we had that free gingiva. There's a demarcation right underneath it where it begins to, it stops being movable and starts being attached. And that's the free gingival groove. And then from here down, it is attached. Then on the, you have to have a way for this to be attached to the tooth. So this part is attached to the enamel. It's not attached to the root. It's from the base of the sulcus. It will be the inside of this papilla is completely attached to the enamel down here. It does not move, and it makes the base of your pocket. And it also, and it's called the JE, the junctional epithelium. Then it connects down here to cementum, and you have your alveolar bone in here, there, and your mucogingival junction we'll talk about shortly. So junctional epithelium, what is it? It's a definition. Anytime you see a definition that says cuff-like band of stratified squamous epithelium, it's the junctional epithelium. It's a cuff-like band. So it's cuff-like because it surrounds the complete tooth. So it's like a cuff. So it's stratified squamous epithelium. It's continuous with the sulcular epithelium up to there. It encircles the tooth to form a very tight seal at the base of the sulcus. And this is what the junctional epithelium's main purpose is to form a big tight seal so nothing can go back and forth. Not a lot. It is not keratinized. It's not rougher or anything. It's like, to give you some examples, your palate is tissue that's keratinized because it's rougher. It's a little more dull. It's thicker. It's rougher, and the part of your papilla, which is movable and shiny and soft, is not keratinized. To give you perspective. So the junctional epithelium joins the gingiva to the tooth surface at the base of the sulcus. It also allows leukocytes to enter the sulcus and to manage a constant microbial challenge that the sulcus has. What can happen when it's not keratinized is it's not supposed to let much in and out, but it can allow, if it's not keratinized, it can allow these leukocytes and cells to permeate through. So here's another description of the junctional epithelium. You can see that what's keratinized and not keratinized. This is really soft. It's not keratinized. Things can permeate through here from the cells. Bacteria can permeate through this way, which is what destroys the bone eventually. All that periobacteria also. Leukocytes can come into it and permeate inside to help with infection. But this non-keratinized part is down here. Is you can't feel that, the junctional epithelium, but it is not keratinized. Attached gingiva. Attachment means it's firmly bound to the underlying cementum or bone. The shape follows the depressions between the roots of the teeth. They kind of go up and down between your roots. It is definitely keratinized. It's much thicker. It's not movable, and follows the depressions between the roots of the teeth. Have that once again. The mucogingival junction. It's a line that marks the connection between the attached gingiva and the alveolar mucosa. Alveolar mucosa is all of this in here. It's soft. If you pull your lip completely out and stretch it, you'll find a part that's attached right here with the attached gingiva, and then you find this part that is not attached. It's often much redder. It has the frenums, the maxillary frenums come down and attach from your alveolar mucosa to your attached gingiva to keep your lips from flapping around. So this is the demarcation, the line between this attached and the alveolar mucosa is called the mucogingival junction. And you can pretty well see it. By the way, when we talk about stippling, it's a diseased tooth they found out can have stippling also. But it always was a sign of health to have stippling. It looks like an orange peel when you pull your lips back and dry them off. You can sometimes see these little pits right there, and it's an orangey peel type of a look. It's called stippling, and always was a sign of health. So here you can see it too. You can see all these little, looks like an orange peel. So here's your marginal gingiva, this white line, and then you have all this attached gingiva, and as you can see, it's not just one line. Here it's like super thin around your frenum, around this labial frenum coming down. And it goes in between here, and then you have that free gingival margin that's not attached. So the mucogingival line is also not a straight line. It can go around the frenum and up like this, and it separates into this really red part, which is alveolar mucosa, and that's often how you see it. You pull up someone, you see a way difference in color here, and that's your line. So here it is. This is non-keratinized. This is keratinized. As far as the teeth go, this is a little rougher and not as flimsy and soft as the tissue above it. So this would be, and this is why we need to know this, is we need to pick out and document, talk to the dentist about when our patients don't have adequate attached gingiva, and we'll say they have mucogingival involvement. So this particular tooth, here's the mucogingival line, and all of a sudden it goes down to here and then here. So if you probe this, it goes right into the alveolar mucosa, and that shouldn't be. So this is, they would have mucogingival or MGI, which is mucogingival involvement. So here once again is the vestibular fold is way up here. When you pull, we have all these different frenums. They all look pretty healthy. And you have your alveolar mucosa. See the difference in color here between the attached gingiva here and this which is keratinized, and this which is not keratinized. You can see it, the same thing down here really well. So here's the mucogingival junction when there isn't such a difference in color. There's a little bit, but look how little they have an attached gingiva here. So it becomes really important that to try to motivate your patient not to be having any, toothbrushing habits that are going to be receding these gums, because if this recedes down and it keeps receding down like this, then eventually they're going to have a mucogingival issue. So this is just to show the different widths of keratinized gingiva that can vary. This is attached gingiva, so see how little it is up here on this canine. So this person really can't afford to have too much recession over their life of that. Right here, this is a little lower. There's a really healthy amount. This is healthy. This is healthy. These are questionable. Got to really watch with their brushing habits. So I wanted to show you what it can look like on an implant. An implant, they have a screw that if you have a missing teeth, they can put a screw, and they screw it into the bone down here, and they put a crown on screws on top, and so the gingiva should be, it probably at one time was up around here, and it has receded all the way to there. So it's now through this mucogingival line. So this is mucogingival involvement on implants. So the alveolar mucosa is movable, loosely attached to underlying bone, smooth, shiny surface. It's very thin. Your frena, freni, frenum, or frenulum, it's all has to do with your frenum. So if you have a singular, what you're talking about, a singular one, it's frenum or frenulum, and multiple are frena or freni. The locations around the mouth, or you have them at the anterior of your mouth, the buccal side, and the lingual side. And we will, I'll be showing you, or probably already have shown you, a tension test to pull the lips out and view all the frenum and make sure that they have healthy attachments. So these are frenums. See how you have these frenums? You put your fingers in and just open up the mouth, and I don't know what this is. I just noticed this for the first time ever. Looks like some instrument. We don't put instruments or anything down on to hold these open. But anyway, okay, so you'll have your labial, maxillary labial frenum attachment. You have frenum attachments all through here. It'll also become important when you're giving injections because you pull the cheek out so that you can miss those frenums. Now the periodontal ligament. The periodontal ligament is also called a PDL. It's a fibrous connective tissue that surrounds and attaches the alveolar bone to the cementum. So this is the ligament, of course, in here, and this would be the bone. This side over here is the tooth. This is just a little cross section as if they cut it out there. So this dentin is the root of the tooth, and covering that, you're going to have this very thin layer of cementum. And then you have the periodontal ligament is attached to there. And on the other side, it is on the tooth socket, the tooth bone, which is the lamina dura. They can call it bone of the tooth socket or lamina dura. So it acts, the periodontal ligament acts as an interface between the bone and the tooth for movement of chewing and masticatory forces. All these ligaments are kind of like the shocks on your car. They're going to be going all different ways to be able to support whatever that we do with our teeth that will still keep our tooth in the socket. So here you have gingival fiber groups. You have gingival fiber and principal fibers. Here's the enamel you can see in the tooth over here. That's the tooth. And you have the sulcus. Then you're going to have alveolo-gingival fibers, and they kind of, in their name, they say their direction and where they attach to and come from. So here's the alveolar, here's your bone and the gingiva. So this alveolo-gingival is going to be principal fibers that go from your bone up to the gingival. These dentinogingival fibers are going to go from the dentin over here out to the gingiva. So they kind of go that way. Then you have circumferential fibers. These fibers attach from they kind of go around the tooth. You can't see it here, but they will also, they kind of take off from the bone and go out this way. Then you have the dentino-periosteal fibers. This is going to be from the bone on this side, and it's going to go around and go into the dentin. So it goes past the cementum and into the dentin. So you've got all these going, all these are all compromising the what's above the root. These dentino-periosteal fibers being a little bit of the exception because they are going kind of partly into the root. Principal fiber groups are also called Sharpie fibers. I remember having that on my boards. What are the Sharpie fibers? So the Sharpie fibers are between cementum and alveolar bone. You have your alveolar crest. So this is going to go from the alveolar crest up this way. You have transeptal fibers. They're straight across. They go from tooth to tooth. You have some fibers that go out this way from each tooth. Here, down here, there's horizontal, that's just completely straight. There's oblique, which is oblique. The shape of them, they run diagonal or oblique. And you have your apical fibers. They're down here by the apical or apices of the tooth root. Okay, so they are all attaching to cementum and bone. So let's talk a little bit more about the cementum. The cementum is a thin layer of calcified connective tissue covering the tooth from the CEJ down to the apex of the tooth, which is the root on a healthy mouth that doesn't have any recession. So the function, it's going to seal the tubules of the root dentin and provide for fiber attachments. So your root has all of these tubules that go out, and that can, when people are sensitive to air or cold, they usually have recession, and the cementum has come off. And so those little tubules on the root are exposed to air and cold and touch, so that can have a really sensitive tooth. But the cementums is to cover that and protect those tubules on the dentin, and also provide fiber attachment. So the characteristics, it's vascular and the nerves are missing. So it is insensitive, the actual cementum. When you take the cementum off, actually scale it off accidentally, then the tooth can be sensitive. So this is the relationship of the enamel and the cementum. So this is enamel, and it can be different ways, and I would know this. This can account for some people's sensitivity when you have not scaled the cementum off, or they have not somehow removed it with some kind of trauma. So on 10 to 40% of people, these never meet. Okay, the cementum is here, and here is the enamel. So you've got this little area down there, and that never was covered by cementum. And so they can be just sensitive no matter what when you're scaling. You have 50 to 70%, so the majority of people are going to have where the cementum in this black line meets the edge of the enamel. Okay, so there is no, unless you scrape or scale this cementum off, it should be protecting, and they should not be super sensitive. But you have a 7 to 14, you have handfuls of people where the cementum goes up over the enamel. So it grows that way. That obstructs the view. And so it actually will go on to the enamel, yeah. Alveolar bone. It consists of the lamina dura, which surrounds the tooth socket or the pocket and supporting bone. It provides support to the teeth and provides for attachment of those perio fibers. So recognition of gingival and perio infections. You do a clinical examination of the periodontium, the gingiva, the periodontal ligament, the bone and cementum, and the perioligament, bone, and cementum, of course, have to be seen on a radiograph since tissue's covering them. So you have signs and symptoms. You may or may not have them. We usually say if there is no presence of inflammation on the gingiva or perio, we say it's clinically healthy or clinically normal. Any cause of tissue change can be alterations produced from disease. The color can change, the size, the shape, the consistency can change. It can start bleeding upon probe, or the patient will come in and say, every time I floss, my gums bleed. So you're going to have some changes. The role of biofilm or plaque, same thing. They used to call it plaque all the time. Now they call it biofilm all the time. Into the disease process. So products of the biofilm has all these microorganisms, and they break down substances into the sulcular epithelium. Then these injurious agents can pass into the connective tissue where inflammation is initiated, and that's the course that it can go. So it produces an increased blood flow to the area, because if there's something inflamed, your body is going to be sending defense cells, leukocytes, etc., into the area. So it's even going to be kind of engorged with more cells to try to help, and it's going to become even more inflamed. So there's going to be more blood there, increase of permeability of capillaries, and more fluids, so it's going to be super easy to bleed. So here's some descriptive terminology on the severity. We always say that for bioplaque or biofilm, calculus, and bleeding, we'll say that they had slight localized bleeding on the upper right, okay, of the gum tissue, or they had moderate calculus on the upper left quadrant of the facial of the upper left quadrant. They had moderate generalized calculus throughout the mouth. Okay, so you have to know what these mean. The distribution, if it's localized, it's usually less than 30% of sites are involved. So if you take 32 teeth and you are going to you're going to be talking about 9 teeth or so in the entire mouth. You're going to be talking about, if 10% would be 3 teeth, then 30% is more. So here's a localized would be less than 30% of the teeth involved. Generalized would be over 30% of the teeth are involved. So you just have to count up the teeth and you'll know whether you can say generalized or localized. A lot of times we just deal with one quadrant, like 8 teeth. So if we're going to say 30% of 8 teeth, and like the one quadrant, you're going to get to, if it's less than like 2.5 of calculus or bleeding, or plaque is on less than 2.5 teeth in that whole quad of 8 teeth, then it's going to be localized. If it's more than that, it's going to be generalized. A lot of times they just put a flat mark and say, because SRP deep cleanings are done this way. If they need 3 teeth in a quadrant done, it's localized, 3 teeth or less. If it's you even have 4 teeth in 8 that need to be deep cleaned, you would go on over to say generalized. So they're pretty strict on that. Marginal is gingival margin. It does not include the papilla. If you say they're marginally red, it does not include the papilla. It's the margin. Papillary erythema would be, or inflammation would just only involve the papilla. Diffuse means spread out. It's rarely ever generalized. If you have something that you get hives, they're spread out. They can be small or they can be large, but they're spread out, but they're just here and there. It's not a complete blanket where you have no clear skin through it, and that's what this is talking about. If it's diffuse, it's rarely generalized. Early recognition of tissue, we are going to mark generalized. If it's generalized everywhere, it's going to be pretty easy for you to see. Subtle is you need more of a skilled eye to see localized changes sometimes. Early recognition and treatment means that the treatment will be less complicated and you'll have a better outcome. And TX, of course, is an abbreviation for treatment. The gingival description, signs of health, of color are pink, pale pink, coral, flesh colored. This would be within normal limits, WNL, capitalized. Changes in disease, if there's disease, it's going to go from dark red to bright red. And that will show that your gingiva has some inflammation or disease. The size, signs of healthy gingiva is flat, pointed, snug around the tooth. When you have disease, the papilla enlarges, the caul deepens, and you have bleeding on probe, which is BOP. Enlargement also, though, could be from drug therapy. Maybe they're doing everything they can to maintain healthy mouth at home, and this is where knowing all the pieces of your puzzle of your patient comes in handy, because on the medical history, if they have marked seizures, maybe they are taking certain drugs for that, and there's a well-known drug, Dilantin, that produces, that you'll see a picture of here real soon, that produces really unhealthy looking gums and doesn't have anything to do with how the patient's taking care of them. So this would be pink, firm, coral, fleshy colored with thin, pointed, healthy papilla. And it would be this way. So this is the drug Dilantin that can, or phenytoin, it's also known as Dilantin, that it's a seizure medication and it can make the patient's gums really swollen like this. And this has nothing to do with how they're taking care of them at home. They can't help it until they get off the drug. So in other words, before you start giving a big lecture to the patient about how they are neglecting their teeth, I would make sure that you don't embarrass yourself by not knowing that they are on a particular drug that's causing that. So this is what we're going to need to know for the intraoral exam part of it. The intraoral exam in our clinic, we look at recession and we try to figure out what the cause is. Is it from irregular toothbrushing, like really hard? Is it hereditary? Some people have really thin gingival tissue that is hereditary. Is it from trauma, some kind of trauma to the gingival tissues? Or is it from periodontal disease, which we need to address? So it may even be from occlusal trauma. They can have people that clench and grind their teeth can have bone loss and recession of the gingiva. So these are the different descriptive words that we're going to put with blunted. It's either healthy, which is that sharp, flat, snug to the tooth, or it's blunted, where it's not all the way pointed like this. It's just kind of blunted down. It can be straight across or kind of rounded. This is bulbous. You see, like that's how we describe that picture of the person with the Dilantin or phenytoin. These are cratered. They, what was happening, this is what I saw on that one picture that had mucogingival involvement on implants. they were cratered down, and sometimes when they're cratered like this, they're kind of a depressed. They've lost the entire papilla, and it could even be cratered even more down, even that, down there. And sometimes pus or exudate is another word for pus or serum that is infected that's coming out, and you could have that. These are rolled, which is exactly what they look like, but the name of these is McCall's festoons. The person, McCall, is the one who came up with this description. And, so he called them festoons. We call them more rolled. But if on board questions they may ask what are McCall's festoons, you would know that it's rolled. It's gingiva that looks rolled. So these are Stillman's cleft. Both of them are called Stillman's cleft, but they're from different things. Stillman's cleft with like a V shape, you'll find this really healthy tissue. It does look like it's blunted. It's not pointed and filling. But other than that, it looks rarely healthy. And then right in the middle of the facial part of this incisor, there's all this kind of pointy V-shaped recession. And it gets calculus, and a lot of times it's sensitive. And so that may be from something that's causing recession on that patient, and it's only causing it in that area. And you can see it's getting awfully close to this mucogingival junction. So you'd want to address that. Sometimes if they can't do anything about it, they'll do a skin graft. The periodontist will take some tissue from the roof of your mouth, and they'll graft it over here and sew it back up, and so that is not an issue anymore. So if it's getting ready to have mucogingival involvement, or it's just making the patient so miserable because nothing they buy helps the sensitivity of that to put on it, then grafting is another option. So this is from recession. Now this is Stillman's cleft also. This is a Stillman's V-shaped cleft up here. This is a slit-like Stillman's cleft. This is from floss. Your floss is favoring, they're putting the floss in, going down here and putting a lot of pressure on it. They're not making a full C around each tooth, and they're making the pressure. They're making these slits with floss. Sometimes they can be on the side over here or over here if they just keep burying down, year after year. And sometimes they can be in the middle. But they're both Stillman's. One is slit-like and one is from recession. Here's what it looks like on a real person. This looks like rolled margins. You can easily see these rolled margins. This is the Stillman's cleft. Up here you can see the slit-like cleft from trying to do a good thing and trying to floss, but they're doing it incorrectly, and then you need to spend some time with them and show them how to correctly do floss. So here's a slit to one side. You can see right here, and it's really kind of red and inflamed there. This would be a cleft recession here, where it's going down. This should be about right here, and there's cleft recession down like this, and these are rolled margins, or McCall's festooned margins. This is another picture of the stippling. You can see, especially if you take your air and kind of dry the attached gingiva off, and it looks really orangey. I don't know what this red thing was on this picture, but it has nothing to do with what I'm going to talk about. What I want you to see is this shiny. See how you have embrasures here, class 1 and 2 for sure, and it looks like food particles or exudate down here. You can see the calculus and stain up on the sides of the teeth, and probably down here. It's probably what all this exudate is coming from, but you can see that it's bulbous papilla, it's red, there's a loss of papilla, it's marginal, it goes, you know, kind of from tooth to tooth on this localized spot, and also from here to here to here. So it's lost its stippling. You can see it's just kind of shiny. So this is really infected tooth. This is going to be a perio patient for sure, and they're going to need deep cleaning. You can just tell from looking. So stippling loss on papilla and gingival margin. You can see how here's the stippling up here and over here, and it should be down on this only, not on the free gingiva, but on the all the way coming down here. It should be on that stippling. This would be gingivitis. This is it's swollen, it's edematous, and that's just what gingivitis could look like. This is BOP. It is bleeding on probe. As you're probing and trying to find these numbers, you can be ever so gentle, and there'll just be this little hairline bleed across here, and that signifies that these are not healthy and they don't look healthy. And this is leukoplakia. It's that white patch that attaches itself on attached gingiva due to some type of irritation, and it won't rub off. If you take that off, there'll be a big bloody area right there. This is another, these are blunted papilla, and it looks like they may have done some type of grafting on this picture right here, because it's a before and an after to kind of close that a little bit. They talk about some, like, what does swollen or spongy look like? They have all these descriptive words. This would be a good idea of something that's swollen and looks spongy. Like if you put your the side of your probe and leaned it on there, it would probably, the mark would probably be left in there. So here's blunting. I would say generalized pointed papilla with localized blunting. You can say between 8 and 9, or you could say on the maxillary anteriors. This would be bulbous again. It's not, and this, of course, this can be hyperplasia. This hyperplasia could be caused by the phenytoin, or it could be caused by something else, some other kind of disease that they have. This would be marginal erythema or marginal redness, but see, you can see stippling up here. It used to be that they said that could never happen on inflamed tissues, but now they know that it can be on healthy and unhealthy places. But if it's more likely, if it's unhealthy, to have all that stippling off and be shiny and smooth. This is more of cratered. It's kind of necrosis or death of the interdental papilla. It looks punched out. Sometimes they'll use the word punched out. This is from NUG, necrotizing ulcerative gingivitis. Would bleed really, really bad. Here's some more. Sometimes you only have like your McCall's festoons or rolled margins on the canines, and probably from brushing and pushing those up year after year, maybe even a little bit here. I'd say it doesn't look like it's down here. I mean, here it does. But on these anteriors, it does not. So on the lower anteriors, so I would say localized and put, upper right, localized maxillary facial anteriors and lower right premolars. This is something that's also spongy and boggy. They'll say, they have a descriptive word that drives us crazy, but it's called boggy. And boggy means kind of spongy. So it's going to dent real easily, and the papilla here are just completely inflamed, bulbous, and just completely out of whack. This is hyperkeratosis. You may have a shiny nodular. It isn't red and inflamed, but it's like shiny and nodular feeling. You can have a hard, leathery, nodular surface when it's something that's hyperkeratinized. So it could be from that. Consistency, you want it to be firm, healthy and firm. If there's disease, it's going to be, you could press it with your probe and it would leave a mark. It'd be soft, spongy, boggy, dense easily. Could be loss of stippling, could be smooth, shiny, bleeds easily. Firm, hard gingiva is related to chronic inflammation with increased fibrosis. So if they have chronic inflammation, which they've had it for a long time, and it may be they can have a really diseased tooth, but the gingiva will look firm and hard, almost like that nodular. It may appear pink and be well stippled. Bleeding on probe is usually only in the deeper part of the pocket, but the fibers have been destroyed when the margin tends to hang down, like even in some of the rolled margins. This is localized recession because there's recession just in talking about this group of teeth. You can have recession that is wide across the tooth, but it's not very much. It's very shallow. You can have recession like the Stillman's cleft right here. Due to recession, it's also takes up most of the tooth and it's deep. Or you can have really narrow and very deep when this has gone through the mucogingival junction. So gingival recession is, we talk about CAL, which is the clinical attachment loss. It's the first letter in each word. And the clinical attachment loss, this whole thing right here should be up here by the tooth. This is the enamel, way up here. So there's this big area and everything has slid down. All these fibers that were holding it up here have been destroyed by microorganisms, etc. And so all of this is visible, okay, to the gingival margin, which would be right up here. So all of this is visible. And then they also have this pocket down here. So what was attached way up here on health has now lost attachment all the way to here. This is only the part we can see, but actually all those fibers have been lost and the bone has been lost. This should be up like this and have a good crestal bone on it. And it's been, these inflammation microorganisms have seeped from there in through here, and they go right to the bone and start attacking it. And so there's a loss of bone level along with the pocket lowering. So this would be the cemento enamel junction. This right here, the CEJ is what we call it. It combines the enamel with the cementum. So it's that demarcation. So the actual clinic loss, like I said, would be from here to up to here. And the recession is, here's the attachment level. So if you were to say what kind of a pocket, what depth of pocket he has or she, they may say, oh, this is a 5 millimeter pocket. So it's, and 3 is even healthy. So this is only a 5 millimeter pocket. And it doesn't sound like it's all that bad of a position to be in. But when you say, look at the clinical attachment loss, though, that is on there. All these fibers have been destroyed, even though it's only 5 millimeters. You've got all this amount. Then it makes a huge difference in your diagnosis. So surface texture, signs of health, pebbled, orange peel, stippled surface on attached gingiva. The papilla center is stippled and the free gingiva is not. It is smooth. So when you have disease, there's inflammatory changes. You could have hyperkeratosis, which on a test question is hard, leathery nodules. Loss of stippling, it's shiny, hard, fibrotic, and it goes along with chronic disease, not something that just came up. It's something that you've had for a while. Bleeding, signs of health is no bleeding. If you have a healthy mouth, you have no bleeding on probe. Changes in the disease, spontaneous or bleeding on BOP, which is bleeding on probe. Sulcular epithelium becomes diseased pocket epithelium and ulcerated. Then you have exudate and separation. So both of these, there's slight differences, but for your purposes, they're pus or fluid filled. It's just something that is on an unhealthy tooth or gingiva and something we don't want. Signs of health are no pus, just gingival sulcus fluid, which cannot be seen. You don't want any of that either. Changes in disease. I can't get back to where I was. Wait a minute. Okay, well, you'll have to finish that on your own when you go back over this. I can't seem to get back to there without stopping this whole thing. So the gingiva of young children, signs of health are pink and slightly, or even just slightly red, because they've always got teeth that were coming in or whatever. Diastemas are frequently seen. Gingivitis is frequently seen, but gingivitis is very reversible. And if someone's really taking care of their teeth, you can reverse gingivitis. A pretty bad case is gingivitis in about 3 weeks, about 21 days. Mixed dentition, the teeth are in constant change of teeth falling out and other ones appearing. Changes in disease, when they have disease, it's very similar to us. And children can have perio disease. They can have gingivitis and they can have periodontal disease. Adults can have both of them, and so can children. A little more rare to have perio disease, but a child can have perio disease. Future test questions. The gingiva after perio surgery. The characteristics of normal healthy gingiva take on very different dimensions. We'll see on the next slide. After they've had like that periodontal surgery, which could be like that graft I was talking about. After they've had surgery, the CEJ may be apical to the JE, which is the junctional epithelium, could be apical to the CEJ, means below it. After healing, the sulcus depths or pocket depths may be within normal range and no bleeding occurs when they're probed, even though they don't appear healthy at first onset. The gingiva around an implant should have the same color as a normal tooth if it's healthy. And gingival grafting surgery is always available with your oral surgeon or your periodontist. So this looks like someone, this is what the gingiva looks like after pocket reduction. This person obviously was having a lot of issues, and look how much bone that they've lost, because if they have this much recession, and they may not have had that much actually, I'll take that back. We don't know what it looked like prior. So they could have had this much recession and wanted to arrest it and for it not to go any further. Or it could have been to here, and when they cut out all of the infected part, this is just the length that it was. This is someone who probably can never take care of all their deep pockets, and they just keep getting worse and worse. And so they will just take the gingiva all the way down, and then have to give this person special, extra cleaning supplies to apparatuses to take home for home care.